doing cardiology again. What we did before was the anatomy of the heart, basically. This one's now going to be dealing with physiology. All right, this is a little bit more thinking to it. In order for us to really understand how an EKG is work, we got to go back to stuff we learned in A&P1 to a point. Something your old friend called the action potential. Well, he's loved it, right? Depolarization, repolarization. Now I'm not going to ask questions about that in the laboratory setting. There will be questions in your lecture, I am sure of it. Okay, so hopefully I can shed some light on that to give you pave the road a little bit for your lecture portion. Does that make sense? But in order to understand EKG, you have to understand action potential, otherwise it just wouldn't make sense. There are questions on the practical exam about the action, or about the EKG. That's why we have to do this. You gotta learn how to crawl before we walk. All right, but I'm not going to go into detail as what a lecture would be with the action potential. It's just going to be set as a review, because hopefully you all remember that stuff. All right, hopefully it'll be review. You just have to review it, not relearn it. There's a big difference between those two words, right? Review and relearn. So, all right, so cardiology. We all remember this whole thing, right? All right. Do I have to draw it up on the board? Referring back to that? All right, so just make sure you know this blood flow through the heart, okay? Now, let's get back to that conducting. Let's review that very quickly. The conduction of the heart, where it starts with the SA node. The SA node fires, and then it's going to give the action potential to both atria. So this one gets it first and then spreads very quickly to the left atrium. As it spreads throughout the right atrium, it then sends its electricity to the AV node, which is also in the right atrium. Then it's going to spread it down something called the AV bundle, or it's also called the bundle of His, H-I-S, it's some guy's name, okay? Then it goes down the interventricular septum as two bundle branches until it reaches its apex, and then it spreads across all of the walls of the ventricle as Purkinje fibers. SA node, AV node, bundle of His, bundle branches, right and left bundle branches, Purkinje fibers. Not bad, it's just weird words, but it's just a five-point trajectory of this electrical impulse, okay? Now, let's talk about the action potential. Action potential, let's talk about the Purkinje fiber. It's a good start for you to understand what's going on here. They excite themselves, these Purkinje fibers. Once they get fired on, they will just, it'll be like a milking sensation going from this one to the other one to the other one to the other one. It'll excite itself going that way. But it'll work as one functional syncytium, meaning like if it's all going to work together. It's going to squeeze here and push it out like this. It's going to milk it that way. It's not going to, this part's going to fire, then this part's going to fire. It kind of works all in one, kind of flows, okay? Now we have diastolic, or the resting potentials. I explained to you the diastole, there's diastole and systole. And we're going to talk about that when we get to blood pressure a little bit later. Diastole is the resting area of the heart. Systole is when it contracts, okay? Diastole, it needs, as I explained to you before, it needs to rest. Your heart will stop for about a quarter of a second. It has to. This is the time when the heart is filling up with blood. You can't be blowing into a balloon and someone pressing on the balloon itself. You're not going to get any air into that balloon. So if someone's pressing on this, when it's filling up with air, the person won't be pressing on it, so that you could fill up the balloon with air. Same thing here. Diastole is a time where the heart relaxes, and this is the time when the heart is filling with blood. It needs to rest to allow that to happen. So the diastolic potential is the resting potential. Okay? There's no contraction happening there. This is not on a flat line. In some cases, it's usually not on, in some potentials, it's on a flat line. In this case, it's on an incline. All right? We call this phase 4. Okay? And this is what we call the pacemaker phase. So let's go through each one. Let's start off with something called phase 0. Phase 0 is that there's going to be influx of sodium from the outside world, okay, from the extracellular fluid. As sodium comes in, is that making inside the cell more positive or more negative? Sodium has what kind of a charge? Positive. So if sodium's coming in, does it make it more positive or more negative? Positive. This is what we call depolarization. Sodium channels open very fast, allowing sodium to flow inside the cell, the cardiac cell, and this makes it more positive. We call this phase 0, and this is when depolarization occurs. Then what's going to happen is it comes to a point where the sodium channels gates close very fast. This is what we call phase 1, the peak. And this is when the sodium gates close. Now, what we also have too is phase 2. Phase 2 at this point is that we're going to have a slow influx of calcium, but we're also going to have a slow output of potassium. So if we have positive going in for calcium and positive going out for potassium, it kind of creates not up or down, it kind of stays flat. Does that make sense? All right, it's not perfectly flat, but it's fairly flat. So we call this the plateau because it reached like a cap. Okay. Then at phase 3, the potassium gates open all the way, and potassium is going to flow out very quickly. Is that making inside the cell more negative or more positive? We're losing all this positive. More negative. So now the action potential is going to shoot down. This is what we call repolarization. Phase 4 was the one I just explained to you before, the pacemaker phase. And now this is going to be because sodium is leaky. It's allowing some sodium to come in. You take your faucet, you tighten it all the way, but on the faucet, drip, drip, drip. There's still water coming out of it. It's leaking. So even when the sodium gates are closed, it's allowing some sodium coming in. That's what's going to contribute to why it's not flat, it's on an incline. As sodium's leaking in, it's making it more positive inside. So it's going to go up a little bit. All right, so this is what we have here. I kind of drew this for you guys. All right, here's the membrane here. Okay, and I color-coded it so it makes it easy for you guys to see things. This is your membrane over here. Here's extracellular fluid, here's intracellular fluid. All right, I should have had sodium like leaking in, so a very small amount of sodium is coming in here. That's going to make this go up. Does that make sense? More positive. Then at this point, the sodium channel gates open wide. And when it does, sodium is going to pour in here, making this action potential go straight up. It reaches what we call a threshold. Once it reaches that threshold, then the sodium channel opens all the way. And it's going to pour in sodium, making it really positive inside, and it's going to go up. This is depolarization. This is phase 0. And then it gets to the point where the sodium channel gates close really fast. Bam! That's the peak. That's phase 1. Now we're going to have slow calcium coming in and slow potassium going out. Slow positive coming in, slow positive going out. Creates more of a plateau. This is phase 2. Then the potassium gates open all the way, and potassium is going to flow right out, making it more negative inside. And we call that repolarization, or phase 3. Then the potassium gates close all the way, and it starts off as the sodium channels are leaky, it's going to go back up like this and repeat itself. Does that make sense? Okay? This is the action potential of the heart, at least of the Purkinje fibers. All right? It's important for you to know, at least in lecture and for the beginning of EKGs, because we'll be using these terms. Okay. Phase 4, just a few notes about these phases. Phase 4 is where the heart rate control is affected here. All right, so when we go back on this, phase 4 is here, pacemaker phase. So heart rate is controlled over here. We can stimulate it more, we can stimulate it less. That's the part we can make it more leaky, less leaky. And the autonomic nervous system will do that. All right? We could have acetylcholine, right? ACH, acetylcholine. It opens potassium channels, allowing more potassium to leave, right? You understand there's more potassium inside, right? Okay, let me show you something here. This is key for you to know, although I made a joke out of it. The salty banana, all right? You need to know what's the most common cation outside the cell and the most common cation inside the cell. You need to know the most common anion outside the cell and the most common anion inside the cell. And this puts it all together. You all know what a cation is? All right. This is sad. All right. A cation. Think of a cat where you're going to have like this. A cation is a positive charge thing. All right, a happy cat. An anion has a negative charge. Okay? Inside of a banana, you learn from kindergarten. What is it loaded with? Potassium. Okay? So the banana is the cell. Inside the cell, it's loaded with potassium. Potassium is a positive charge, so you're going to have the most common, most abundant cation inside the cell is going to be potassium. Outside, you put salt. What do we refer to as salt? Sodium chloride. So you're going to have tons of sodium outside the cell, and you're going to have tons of chloride outside the cell. Inside the cell, you will have chloride and sodium, not as much as you have on the outside. All right? For potassium, you will have loads of potassium inside the cell. The salty banana. Does that make sense? So if potassium channels open that are on the membrane, no diffusion, if they open, which way does potassium want to go? Out of the cell or into the cell? Out, because you have more. If you have, let's say, 50 students inside the cell, and you've got 2 students outside the cell, when those doors open, which way do those students want to go? Out, right? It's just simple diffusion, all right? So when potassium channels open, potassium wants to go outside. When sodium channels open, which way do they want to go? Inside. There's more sodium outside than it is, so it goes this way. If chloride channels open, does it want to go into the cell or out of the cell? In. There's more of it over here. The only one I didn't really put in here, and you'll just have, that's the only part you got to memorize, the most common anion here is going to be phosphate. All right, that's the only part you got to memorize, but I don't want to go into that. All right, does that make sense? You need to know this. This is AMP1 stuff, chapter 3 stuff, but you need to understand that. Okay? Otherwise, you'll be lost on this stuff. Which ways it go? All right, they're going to ask questions on the lecture exam. Potassium channels open, which way does it go? All right, but that's the reason why, just simple diffusion. Okay? So, if it opens potassium channels are going to allow the potassium to go out or in? Out. Does that make it inside more negative or more positive? Negative. Okay? So that's going to decrease the depolarization rate. It's going to hyperpolarize, new words, but it's going to go the opposite of depolarization. So depolarization will decrease. When that decreases, your heart rate will go down. All right? When it goes down, we have a term called bradycardia. If your heart rate is less than 60 beats per minute, we call it bradycardia. Brady meaning slow, cardia meaning heart rate. All right, that's a term you need to know. Okay. Then we have norepinephrine or adrenaline, noradrenaline. What that's going to do, it's going to increase the number and rate of opening sodium and calcium channels. When you open up sodium channels, does sodium want to go into the cell or out of the cell? Does it make it more positive inside the cell or more negative? Positive. When it does, it's going to increase the depolarization rate, making the action potentials closer to each other. That's going to increase the heart rate. If your heart rate goes more than 100 beats per minute at rest, all right, I'm not saying run a marathon and, oh my God, I got tachycardia. Well, no, that's not at rest. Right now, if you have a heart rate of 150 beats per minute, we call that tachycardia. Tachy meaning fast, cardia meaning heart rate. Okay? Questions on that? All right. Another thing about phase 2. The longer the plateau phase, the greater the calcium coming in, meaning the greater the force of the next contraction. Okay? This is the time where you want, if you make a long plateau phase, it means that the heart is contracting really long. We could actually make that longer by keeping the calcium inside. How do we do that? We can give you a medication to block calcium channels from allowing to go back outside. So we keep the calcium inside for a longer amount of time. It's a medication called calcium channel blockers that are going to keep calcium in there for people with congestive heart failure. They need their heart to pump for a longer amount of time to get more blood out. So people with congestive heart failure are going to be put on calcium channel blockers to keep the calcium inside to make the heart pump more efficiently. Does that make sense? Okay? So this is showing you normal beats, right? Action potential. If we put sympathetic charge to it, right, more adrenaline, then it beats faster. You'll see that these potentials or action potentials are closer together. This will increase the heart rate. If you have acetylcholine, parasympathetics, then it's going to pump slower. The heart rate will pump slower. Okay? Now, I showed you the action potential of the Purkinje fiber, but you have to understand action potentials are different in different parts of the heart. I'm not going to go through each one. I'm just going to give you some highlights of what makes it different when you compare it to the Purkinje fiber. The action potential of the ventricle, it's the same as the Purkinje fiber, except the resting potential is flat. It's not on an incline. There is no leaky sodium channels there. So there's no slow depolarization drift. And the cells don't excite themselves. They need something that's going to tell it what to do. The bundle branches are going to do that. Okay? So this is what it kind of looks like. Notice it's flat here. It's not on an incline. And the phases are all there. Okay? And it's showing you what's happening here. Kind of like when I drew that picture before. It was up there. But now you can see sodium coming in, it's going to depolarize the calcium and the potassium doing all this stuff on the membrane. Okay? The action potential of the SA and AV node. They're the same as the Purkinje fibers, however, there are no sodium channels. Instead, calcium is the one that's going to depolarize things. There is more calcium outside the cell than inside the cell. There's just a lot more sodium outside the cell than calcium. That's what I'm saying. There's more of abundance. The salty banana goes with that. But there is more calcium outside the cell than inside the cell. So if the calcium channel is open, it's going to pour it inside. Calcium has a positive charge. Actually, it's positive 2. But it's positive. So when calcium comes in, it's going to depolarize the cell. Okay? So when you look at this, here's an action potential in the ventricle, here's it in the atrium, and here it is in the sinoatrial node, or the SA node. They're different. Action potentials are different depending on what part of the heart. And this is going to lead to what an EKG is all about. Okay? So let's talk about the EKG, electrocardiogram. Basically what this is that, and you know a little bit about EKGs. You know there's going to be electrodes on the person's chest, all right? There's 12 leads that we do, and we have one over here, but we're not going to do 12 leads. We're only going to do 4. These are not the best EKG machines, but you could see things, okay? You're going to have like 12 leads. We have 6 leads that go around on the chest. 1, 2, 3, 4, 5, 6. Kind of goes right across here, and they have certain places to put them, all right? Then you're also going to have 3 other leads on the 2 wrists and usually on the ankle. There's other leads, and this is going all around the chest. The chest leads go right to the heart, so there's 6 right across there. But then how do you explain this? There's only 3 here. Well, they sense the electricity through the heart from your wrist here to your ankle, and from your ankle to your wrist. There's 2. From this wrist to this wrist, that's 3. From this wrist to this wrist, that's 4. From this wrist to your ankle, that's 5. From the ankle to this wrist, that's 6. These are called the limb leads. I'm not going to ask you about that, but you guys are going into the health fields, you should have some idea what's going on here. Okay? So we have a total of 12 leads, and we can actually see these leads will pick up the action potentials of all different aspects of the heart. But the action potentials, as you just saw, are different on the heart, depending on the AV node, SA node, Purkinje fibers. So what these leads are going to do, they're going to pick up all the different action potentials of the heart, put it into a machine. The machine is going to take all that information and spit out one EKG that's a conglomeration of all the action potentials that are on the heart. And a good cardiologist will be able to look at that EKG and know what the action potential looks like in the SA node versus the Purkinje fiber. We're no way going to be going into that. But I want you to understand what an EKG is. It's not an action potential, although you probably saw an EKG look like that. That is not an action potential. That's a conglomeration of all the different action potentials that the heart has. But now it's going to be fused into one machine, and the machine's going to spit out this EKG. And this EKG has a number of waves, we call them, complexes, knowing how high they are, how close they are, if they're there, if they're missing, if they're a different shape. That's where cardiologists and nurse practitioners, they can read that and say, we know what's going on with the heart, because we know what it normally looks like, but this is a little bit too high, so there's probably too much potassium in your blood and things like that. So this is what it is. Your heart does all the action potentials. In the SA node, the action potential looks like this. The atrial muscle looks like this. AV node, it looks like this, and so forth. It's gonna, those 12 leads are gonna take all these action potentials, it'll convert it into one conglomeration to this. This is all your action potentials into one picture called an EKG. okay? And that's what we have to do now, is to talk about the parts of the EKG and what do they mean. Does that make sense what this is? I guarantee there'll be questions on your lecture exam with the action potential. There's no way you could do A and P2 and not even understand the action potential of the heart, all right? What's the #1 killer in America in women? Heart attack. There's a little trick thing. I want to see how many people would say breast cancer, all right? No, #1 killer for men and women in America is heart disease. So I guarantee, and this is what you should do, you should know the top 10 killers in America. I guarantee every test that you'll have in wherever you're going to go, physical therapy, occupational therapy, all the standardized exams, they are going to ask you questions about the 10 top killers. Because these are the things that are coming into the hospitals. These are the things that are coming in doctors' offices, in the clinics. So they want to make sure, how much exposure do you know about these diseases? Because this is the one where the big businesses are coming into. You know what I'm saying? They want to make sure you know the killers, the 10 killers. They're going to ask questions about Down syndrome and other things, but they want to make sure you are very well adapted when you can deal with the 10 top killers. So you better know everything about heart failure and stuff. Okay? #2 is cancer. Other ones that are on there you would be surprised about is Alzheimer's disease. Is the #6 killer in America. All right? It's not because they forgot to turn off the stove. I mean, that could be part of it. But it's, you know, what happens is the brain deteriorates. The cerebrum goes first, so you're forgetful, but eventually goes to the brainstem, and you don't wake up. All right? So you need to know the 10 top killers. I guarantee it. And the other thing, when you get into pharmacology, you better know the 50 most frequently prescribed medications. These are the things that are going to be on your board exams. I guarantee it, 125%. Okay? All right. So let's show you the parts of the EKG. All right? The resting phase, which is going to be this here. At this point, this is diastole. At this point, the ventricles and the atria are relaxed. There's no contraction going on. There's relaxation. This is where the chambers are filling with blood. Okay? Then what happens is something here, you got this little bump called the P wave. The P wave means that this is where atrial depolarization occurs. Atrial contraction occurs. It's going to put whatever blood is left there, usually 30%, and it's going to push that or squeeze that blood into the ventricle. Most of the blood, 70% of blood, just goes in because of gravity. But there comes at a point where the right atrium and left atrium squeeze whatever's left there. When it squeezes, you will see it on here as a bump, a P wave. Okay? At the end of this P wave, the atria are fully contracted. They didn't relax, it's fully contracted. Then you have the PR interval. Okay? The PR interval from here to here. Now, it's really the PQ interval, and I don't know why they just used it over here. Because this here, we're going to talk about the QRS complex. It's really the P to Q, but they call it the PR interval. You just have to accept it. It's on that list that I have that I'm going to bring up there. All right? You just have to accept it at this point. This is where we have the conduction, the electricity going from the AV node to the Purkinje fibers. This is where the atria contract and they begin to relax, right? So they're going to be fully contracting here, but they're going to start beginning at the end of the PR. It's going to relax a little, or start to relax. This is also the time at the end here, the ventricles begin to contract. Okay? So you can understand that to read these things, if this becomes like a longer area, there's something going on here. It shouldn't be that long. So that's where they measure things, and they get an idea with this. You have these little graphs, these boxes, which we'll talk about. Then you've got this QRS complex. QRS complex. It has a very high spike because the ventricles have a thicker wall than the atria. So it's much higher. Okay? This is going to be a short time compared to the P wave. The P wave is relatively wide. This one's relatively short. Because electricity in the ventricles happens much quicker than in the atria. And it's partly due because of the way the Purkinje fibers are set up. At the end of the QRS, the ventricles are fully contracted. Now, during the QRS, this is also the time when the atria relax. But you can't see it on an EKG because the massive thickness of the ventricles has masked this area. So you just see on here the ventricles contracting, but in there too is where the atria relax. You would normally see some sort of wave there. You can't because they're thin compared to the ventricular walls. Okay? So when the atria relax, we call that atrial repolarization. Okay? So the P wave is atrial depolarization or atrial contraction. The QRS is ventricular depolarization or ventricular contraction. But also in there, you're going to get atrial relaxation or atrial repolarization. All right? Then you have the ST segment, this area right here. This is where you have complete contraction of the ventricles. If you remember, that's the part where the plateau phase is. In someone who's got congestive heart failure, that'll probably be pretty small because it's not going to last that long. So we have medications that will make that last longer so you can have a longer contraction to squeeze out extra blood as much as you could, to make the heart be more efficient in congestive heart failure. Then you have this T wave over here. And this is where we have ventricular repolarization. This is where the ventricles are going to relax. You can see it there. Again, you can't see the atria relax over here because the QRS is so massive. So at the end of the T wave, you will have both atria and ventricles relaxed. And you start over again. That's the resting phase, the diastolic phase. That's the point where, again, it's going to fill up with blood. And the cycle repeats. Does that make sense? Busy. The atria relax, yeah, from here, all of this to here. Yep, absolutely. But during that time, you also have filling of blood, but it's just going to contract during the P wave.
But it's a diastole.
Diastole. Okay? That's why I had to talk about the action potentials to make you understand what repolarization and depolarization is all about. All right, so this is what's happening with the heart. If you look at this animation, I'll let it run a couple times, but you get to see the action, or the EKG and the electrical impulse through the heart. Okay? If you watch it about 10 times, you'll see where everything is going. All right, I'm going to do 10 times, you can do it at home. All right, and here you can actually see another way where the P wave is, and it goes around this whole thing. You can do it that way if you want. What happens with the EKG and the heart. You can also see it this way in one picture form with the EKG and where the electrical impulse is. Big questions in your, at least the cardiac area of your lecture, okay? So this is just a summary of the parts of the EKG and what they do, okay? Let me ask you this. You get an EKG, here, okay. You walk 10 blocks. No problem. You know, but for the past couple weeks though, I walked 10 blocks, I'm out of breath after 1 block. I get an EKG. It shows some abnormality. It's missing a P wave. What is that telling me? The atria are not contracting. What makes the atria contract of that electricity? SA node, AV node, that whole thing. The SA node. So if there is no P wave, then the SA node's not firing. Does that make sense? So this is what normally, here's the PQRS-T. PQRS-T. Look at this. No P. You have a QRS-T, QRS-T. You see? You're getting to read EKGs now. I'm not going to get it heavy, but you could have some idea. If you understand what each part is and what each part represents, then if that part is removed. This is how I teach. If you haven't caught on to my style is not just memorizing things. A P wave, what does that do? Oh, it just, it's going to be atrial depolarization. Yeah, but what does that mean? What happens if we take it away? And what can be possibly wrong? I'm doing the same thing as all other teachers, but I'm doing it in a different way. I want you to know how to use this stuff, because this is what you're going to be asked in your future. So you might as well get your brain wired thinking about this if we remove it, okay? All right, so how can you read EKGs? This is just a very schematic thing, but I'm going to show you how you can get some idea how to read this. You have a systemic approach to it. You look at it, what's the heart rate? And I'm going to show you how you can pick out the heart rate over here, okay? See what the rhythm is, okay? Is there a QRS with every P wave, okay? Is there a P wave there? All right, the PR interval, you want to comment about that. See how long, how long that is, how short that is. Comment about the QRS complex. And then there's something called an axis, where we can actually see there's more pressure on the left side versus the right side. You can actually see right or left congestive heart failure. Now, I'm not going to go into all the details here. I'm more concerned with the first 3 or so. But over here, if you need to go further into this, because I do have students who are in nursing and they want my EKG stuff because they're going to ask questions on it, so they need something basic. But what I'm going to show you is like basically the first 3 things on here. Okay, that's all I expect you to know for the exams. So again, P, QRS, T. Okay? Atrial contraction, ventricular contraction with atrial relaxation hidden here, and that's ventricular relaxation. Okay? Now, we got to talk about these boxes that you probably saw on there. We have big boxes and short boxes. We have the x-axis and the y-axis. The x-axis over here is time. That's pretty easy to manage. The y-axis up here is voltage. How much voltage is going into that EKG machine? I won't ask you about what each second is in small boxes and big boxes, but can you see the small boxes? That's the small box. There's a big box. Do you see the darker bolded line? There's another big box there. The You're going to have to count these. Okay? I won't ask you what each one is, but just understand volts, millivolts are on the y-axis, and seconds are going to be on the x-axis. But don't worry, at least for this class, you don't have to worry about 0.1 millivolt and stuff. Now, how do you determine the heart rate by the EKG? There's about 6 different ways you can do this. Some are better than other, more precise. I'm going to show you one that's not so precise, but it'll get you to understand the concept. Okay? What you do is that you note the RR intervals, where those big points are in the QRS. Look at the big point, and you want to see what the spacing is between the big points. The RR intervals. That R is up there, the biggest point. And then you want to count the number of big boxes between them. Please, the big boxes. Don't count the little boxes. When it goes on the practical exam, people are saying that there's like 150. It's not 150. It's only like 3. You know what I'm saying? That kind of thing. And then you're going to get the wrong answer. It's the number of big boxes, not the number of small boxes in between the RR intervals. That's the easiest way you can find the RR or the R, or where you're going to count them, is see if there's an R that's right on the solid, like the bold, dark, the bold, thick line of the box. I'll show you what I mean by that. All right, it's easiest to find it that way. And then you're going to correlate the number of boxes in between the RR interval with this part. This is the part you got to memorize. If there's 1 or 2 or 3 or 4 or 5 or 6 big boxes in between there, then they correlate to these numbers. If there's 1 box between there, it's 300 beats per minute. If there's 2, it's 150. If there's 3 boxes, it's 100. All right, so 300, half of 300 is 150. Minus 50, you got 100. Whatever you do to memorize them, but you should know it to at least 6. All right, that's not too bad. If there's anything you got to memorize, that's not too bad. All right, so how do you do this? You see the dark lines. You see the small boxes. You're not counting the small boxes. You're counting the big boxes. So I try to look for one to make my life easier. I try to look for the R that's on a dark line. Like there. You see it's right on the line. I could do it with the other ones. I'm just saying it's easier if you can find that one. You can just scan it really quickly. So there's right on the dark line. You see it? So you just count the number of big boxes. 1, 2, 3, and not quite 4. See it? So I just go 300, 150, 100, not 75. It's somewhere between 75 and 100. It's closer to 75, so I'm guessing maybe about 80 beats per minute. Do you see? So these are the big boxes, how you're doing it. So you'll count it. 1, 2, 3, not quite 4. So this would be about 80 beats per minute. This is if the rhythm is the same. Some people have skip beats and stuff, and you can't do it this way, because then the RR intervals are all different. There's other ways you could do that. If I'm going to give you something, I'm going to give you something that's going to be easier to count. It'll be a regular rhythm. All right? Does that make sense how to do this? That's pretty easy. You're just counting. But it's the big boxes. You'll get the wrong answer if you're counting the small boxes. Okay? So the rate, what's the rate? Beats per minute. Okay? If it's faster than 100 beats per minute, then we say it's tachycardia. At rest. Right? You're not running a marathon and then it's 150. No, that's not it. If you're at rest and you have a fever, your heart rate's going to go up. Sure, you're tachycardia then, but that's an appropriate thing because your body is trying to push the blood to where the infection is. If it's less than 60 beats per minute, we refer to it as bradycardia. Okay? So I might have on a practical exam, give you a strip, what's the number of beats per minute, and tell me if this is normal, is it tachycardia or bradycardia. And you'll be able to do that in 1 minute and a half. That's not bad. All right? We refer to a rate as sinus if for every beat you have a P wave going with a QRS. Okay? So you can have that during tachycardia, and then we say it's sinus tachy, or tachycardia, or sinus bradycardia, telling us, yes, it's a fast heart rate, but there's still a P wave and QRS with each beat. Does that make sense? Okay? We could just say that your sinus, I mean, it's normal. So this is sinus tachycardia. If you count these, it's going to be like about 100, 150. But there's a P, QRS, P, QRS, P, QRS. So therefore, this is sinus, and because it's going so fast, sinus tachycardia. Okay? Rhythm. Is it regular? Are the, God bless you, are the RR intervals the same in between? The same space, the same number of blocks in between? We could have regular, irregular, meaning that it's irregular, but there's a pattern with it. So it's going bop, 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 bop. Normally it would go bop, 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 bop. But now you got bop, 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 skip, bop, 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 skip, bop, 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 skip. So there's a pattern there. So we say that it's regular, there's a pattern, but it's still irregular. Then you could also have irregular, which means that it's skipping a beat and there's no pattern. Bop, 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 bop. There's no pattern. Does that make sense? Okay? So look at this. P, QRS, T. P, QRS, T. And notice that the P, between the P and the QRS, there's a space there. This one, the space is longer. This one, its space is so long that it skips a QRS. And then it goes back. There's the PR interval is very small. This one here, it's longer. This one here, it's longer. This one here, it skips. There's a pattern going on here. It's still irregular, but there's a pattern that's going on. Every third one, it skips a beat. All right? So we say that's regular, irregular. Sometimes you need a longer strip to see that. So on EKG, you'll have a bunch, they'll have one for each one of the leads, but you'll also have ones that are longer. So you could actually see if it's, you can't see it if it's only like showing only 3 beats. So you need something that's going to show like 10 beats, so you can see if that's there. This is irregular. The spacing in between the R intervals, there is no rhyme or reason. It doesn't make sense. There's no pattern there. P wave, are they present? Right? If it's not present, then you know the pacemaker is not firing. All right? Are they the same? Do they look like the same shape on all of them? Something else could be going on. Okay? Same thing here. What's the morphology? What does it look like? Okay? Are there more P waves than QRSs? That means the QRS is skipped, meaning that left or that ventricle is not contracting if there's no QRS. So sinus rhythm over here. All right, meaning there's P QRS. And here, I know they look weird. You'll learn about these in another class, but there's no P wave. So there's no P. You got a QRS, and here's the T. QRS, the T. QRS, the T. There's no P wave. So I know that there's no pacemaker working over there. Does that make sense? All right. And it's just showing you here that the P wave, see how this one's round, but then this one's more spiky. So we look at this kind of stuff. I wouldn't ask you about that, but some people have, I think a lot of people have more interest in cardiology in our A&P classes than hematology, than endocrinology. I bet you everybody in this room knows someone who's had a heart attack, if not themselves. So you have just a natural attraction to this because something, you know people with heart disease. Okay? There's more P waves in this, just so you can see it compared to the QRS. Okay? You know, and you would ask yourself, I wouldn't ask you this, but is the P wave, the PR interval, is it long, is it short, does it change at all? These are the kinds of questions that go into your head as you look at it when a doctor or a nurse practitioner looks at EKG. This is what's going on in his or her head when they look at EKG. Is it normal or not? Okay? I don't trust the computer telling me what that is. All right? I don't trust computers as much as I do. I love computers, but I don't trust them fully. When I do Scantrons, I don't do the Scantron machine. I grade it manually. I have these little cards I put. I trust me more than a computer. All right? How many people actually really listen to the GPS and then you drive off a cliff? All right? Okay? So this is showing you long PRs. I showed you long, and then really long. Okay? And these are short PR intervals. All right? So these are just more EKGs you can do. QRS, is it really wide? Are they the same? Is it high, low? These are questions that, you know, they would ask themselves. Okay? So you can see here, wide in QRS. QRS here is very narrow. Over here, QRS is very wide. It looks weird, I understand, but we're looking also, a lot of things we get comment about the QRS. Not just that it's weird, we also see that it's very wide. It lasts for a long time. And axis deviation, you don't have to worry about that. It's just if you know anything about this, is where the other question would ask. It's just telling us, is there more force of contraction on the left side or the right side? Is that heart muscle getting bigger on that side? Because that could tell you a little bit about congestive heart failure, what your blood pressure is and stuff. So I'm not going to go into that, but if you have an interest in EKG, you could read more about that on your own. Okay? So some of normal EKGs, tachycardia going really fast, fibrillation, ventricular fibrillation, meaning that it's uncoordinated, and it's not going to make that ventricle contract. This is where you would go boom with electricity to put a shock to it, to say, hey, look, snap out of it. You know, like you want to smack someone in the face, just snap out of it. You're having a conniption. Same thing with the heart here. Snap out of it, and hopefully that works. That little news for you though, that little electrical stuff usually doesn't work. Okay? The only time it really works is if the person drops dead right there, right in front of you, within the first minute or so. Yeah, but they're doing this kind of thing for a number, you know, like the person was lying down here, you don't know how long they were here, for 20 minutes. It usually doesn't work. I think the TV misleads people. Oh, just shock them. Just usually doesn't work, because unless they see it right then and there, it usually does, but afterwards it just doesn't. Okay?